Dr. Pimentel, and welcome to the GI Health Summit. Thank you so much for being here.
No, it's great to be here.
Well, thank you. You know, Dr. Pimentel, a lot of people talk to me about their health, and one of their biggest concerns seems to be gut health. It seems that there's so many people suffering from things like bloating, IBS, SIBO. Why do you think that is? And more importantly, what can we do about it?
So that's a very big question, AJ, and so the question that we've been thinking about is it getting worse? Are more people suffering with it, or we have a greater degree of awareness, or maybe a little bit more openness in society to be able to talk about our bowels? Remember, it's not exactly the ideal topic of conversation at the dinner table, so some people were suffering in silence. There's another thing that was, I think, suppressing patients' desire to talk about their bowels, is that people used to think of IBS and these kinds of functional disorders as psychological, or that it's in your head. And so maybe people wouldn't want to relate this out into the community or into their friends, because their friends might think that they're, quote, crazy, or that they're not normal. And so I think now that we understand that that's not true, so I think that's very helpful.
Great, thank you. So not everybody knows what IBS or SIBO is. Would you mind explaining it, preferably in layman's terms, so people can understand what these non-in-your-head conditions are?
Sure. So this is some point of confusion as well. So I think it's a very good question, because irritable bowel syndrome is a terminology that's used for almost a wastebasket of patients, meaning, you know, you've had a colonoscopy, you're suffering from diarrhea or constipation with pain and bloating, and then the doctor does a workup, can't find anything wrong, and then you're subjected to a list of symptom criteria, and if you meet those, you're called IBS. The problem with that, and the reason the term wastebasket, is because there's no objective, or was no objective test for IBS, you're sort of left hanging. Is it IBS? Is it something else? Do I need to go to another doctor? Do I need to check it out and with other people? And so that's sort of what IBS was. Small intestinal bacterial overgrowth, or SIBO, is that there's a buildup of bacteria in the small intestine where they don't belong. So there's too much bacteria there. As a result, when you eat, the bacteria are sharing with every meal you eat, and they produce a lot of gas, and you get distended, pain, and diarrhea or constipation, depending upon the type of SIBO. So now, how do those fit together? And people get very confused, because they say, well, do I have SIBO, or do I have IBS, or do I have both? And so what I like to frame it as now is that I don't know how many people remember ulcer disease, and that H. pylori, a bacteria, is a cause of ulcers. But back in the 80s, it was highly controversial, but about 60 to 70% of ulcer patients, a bacteria was identified that was the cause of the ulcers. And that's what we're seeing here. About 60 to 70% of people with IBS, bacterial overgrowth, is a cause of those symptoms, and treating it makes a lot of the symptoms go away. So we didn't change the name of ulcer disease, still ulcer disease, nor will we change the name of IBS, but a component of IBS is caused by bacteria. And now that we know that, we can treat it, and also that it's not in your head.
So would you say, though, that everybody that has SIBO has IBS, but not everybody that has IBS has SIBO?
Right, and that's again a perfect analogy for H. pylori. So millions of people have H. pylori and never have an ulcer, so there's nothing to do about that. In the case of bacterial overgrowth, there are people who have bacterial overgrowth who don't have IBS. For example, another cause of overgrowth is adhesions. So if the bowel is blocked in some way, bacteria will build up. If you're on narcotics, bacteria will build up. If you have pancreas disease, sometimes bacteria, diabetes, cirrhosis of the liver, those are all causes of buildup of bacteria, and they're not IBS. So you can have bacterial overgrowth from other reasons, but IBS really, because it's the largest GI disease in the world, nearly 1 billion people in the world have it, that's going to be the bulk of the bacterial overgrowth also.
How can it manifest, though, both as diarrhea or constipation? And sometimes even both in the same person, if I understand this correctly.
Yeah, so we've done a lot of this work over the last 20 years, is that when certain bacteria build up, and this reflects on even recent papers we have, two types of bacteria build up in the small bowel, or this is data that's just emerging. E. coli and Klebsiella, those are like weeds in your garden, or weeds on your grass. So if you don't mow the lawn, you'd be surprised the grass goes away and the weeds take over. And so that's sort of what's happening in the small bowel. E. coli, Klebsiella, two bacteria that are opportunistic and they love to take over when they can. And that's what we think is going on with the diarrhea component of IBS. On the constipation side, it's not even a bacteria, it's an archaea or an ancient sort of bug called methane producers, or Methanobrevibacter, if you want the technical term. When that organism takes over, it produces methane, and that constipates you. So depending upon what's overgrowing in the gut will dictate what your symptoms are, constipation or diarrhea.
When does one decide to seek the help of a gastroenterologist to figure this out? Because people can't self-diagnose SIBO, they have to have a test, correct?
Right. So, we've been part of the process with testing for IBS particularly. So we've actually come a long way in 20 years. We now know food poisoning is the trigger for the sequence of events. So you were fine, you went on a trip or you went on a cruise or something, and then you developed gastroenteritis, which is food poisoning, and things like salmonella that you hear in the news, or Shigella or Campylobacter. These are things that can happen from unprepared, poorly prepared foods. And then ever since then, you have, quote, IBS. And we now know the toxin in there that causes the IBS. And we know that toxin can lead to autoimmunity to your gut. And that's a protein called vinculin. So it forms the basis for a new blood test that's available that says, for a primary care physician, this is great because a primary care physician wasn't able to easily diagnose IBS before. Now they do the blood test, it's positive. It came from food poisoning, you had IBS, and you as a 24-year-old woman don't need to get a colonoscopy because there are too many colonoscopies being done in young people with all negative results. And it's very expensive and also hard for patients to go through that. So that's a very big advancement that I'm proud to say we were part of. In terms of assessing or diagnosing bacterial overgrowth, breath testing is more widely available than ever, and so even a primary care physician could do it. Where I would see that a patient would see a gastroenterologist is if the blood test for IBS is negative, then you don't know what's going on, and you might need further assessment by a gastroenterologist. So that's how I sort of operate now, is that if you have diarrhea for a year or intermittent diarrhea for a year, do the blood test. If it's negative, then see a gastroenterologist and get the further workup. And if you don't know how to do breath testing, the GI doctor certainly does.
And breath tests are nothing to be scared of. They're not even invasive. They don't take your blood, or they're very easy.
The most stressful part about the breath test is the stuff you see on your iPad while you're doing the breath test, because you're just sitting there and breathing in the bag every 15 minutes. So there's nothing invasive. There's no blood. There's no IVs or nothing like that.
So one symptom that I seem to hear from a lot of people is bloating. And bloating is often a symptom of both of these conditions, IBS and SIBO, but sometimes it's not, right? And that is the symptom that I think people complain about the most, because it makes them, especially in women, it makes you feel just terrible. It makes you look fat. So what can we do about bloating?
Yeah, so the funny thing about bloating is that the irritable bowel syndrome, there was a study that was done in IBS, and I'm not trying to distract away from just the bloating symptom by itself, but this is the problem with bloating, is that because people didn't know what to do with it, and I mean doctors didn't know what to do with it or how to treat it properly, they took it off the criteria for IBS. So if you ask 1,000 IBS patients, what's your most bothersome symptom, even though all IBS patients must have abdominal pain to meet the criteria, bloating was still the number one symptom. And so that's what's bothering patients, and that's what's causing the cramping, and that's the real number one symptom. And I agree with you that it's not just bloating. Okay, so I've seen thousands of patients, and what patients describe to me in terms of bloating, doctors are like, it's bloating. Who cares? That is not the approach, because the patients are suffering. And I can tell you, if you're bloating to the point where it's painful and it's pressure and it's hard to breathe sometimes, it is not a mild symptom. And you have that at a restaurant with a group of people around the table. You can hardly talk and communicate. You can't focus. You can't concentrate. You can't socialize. It's very difficult, not to mention the appearance or your physical appearance and how that affects what you wear, how you feel about yourself. And it's really one of the troublesome symptoms. So again, the breath test is helpful because if it's bacterial, you don't get bloated without gas, in my view. It has to be overproduction of gas in the gut to make that happen. And so the only thing that overproduces gas is bacteria, sometimes yeast, and you have to figure that out and try to treat it.
So are the symptoms for SIBO pretty much universal across the board for most people?
So we're continuing to unravel this. We have a big study called the Reimagine study at Cedars, where we're taking juice from the small intestine and stool from ongoing. We're hoping to get 10,000 samples over a period of years. But we are already seeing that certain bacteria, if they're elevated, are more leaning towards the patient having pain versus other bacteria that are elevated more towards bloating, other organisms more towards constipation. So we're going to be able to type patients with time. I can't give you the exact answers on what that's going to look like yet, but give us a couple of years and we'll be able to type people. And then what that allows is precision treatment, because if you know the type, you know the treatment for that precision, finding, and that will help patients immensely, I believe, in the future.
Other than through food poisoning, are there other ways that people are contracting SIBO, and how are they getting it?
Yeah, so we sort of touched on this earlier, is that poisoning is the major cause, and I've already told you that there's a blood test for determining that that food poisoning was the cause of this constellation of IBS/SIBO. But then narcotics, other diseases, anything that causes the bowel not to move well is another cause of SIBO. And so there's a number of things that need to be thought about. The thing that always alarms me, and I've seen this a number of times now, a patient who's gone to their doctor, and I'm not trying to alarm your viewers, but there are people who go to the doctor, they get treated as SIBO, and they've been treating as SIBO for 6 or 8 months, and it's not working. So if you get treated for SIBO and it works brilliantly, great. If it doesn't work, or you get treated and the bloating just doesn't go away, you really do need to see a gastroenterologist, because we found patients who have tumors of the small bowel that are causing blockages. I have one patient who had a pancreas cancer that wasn't recognized, and people were fooling around with SIBO for too long. And so you have to be cautious that if you don't respond well, think of other things. And I'm not talking about the 24-year-old, because the chance of cancer or something like that at that age is unusual. I'm talking about the 50-year-old, the 60-year-old, the 70-year-old. Don't spend too much time just treating SIBO. Start to think about other things that could be causing the SIBO.
I know you mentioned that for a 24-year-old, you wouldn't want to routinely do a colonoscopy. Where do you stand on colonoscopies for people? At what age do you believe that we should be having them, and how often?
Yeah, so one of the stories that I tell at a lot of lectures is that I have a patient in my clinic. This is a true story, and she's 24-year-old. That's why I mentioned the 24. And I saw her for the first time. She clearly had overgrowth, clearly had IBS based on my experience, and it turned out that was true. We treated her. She did great. But during that first visit with me, I said, "Have you ever had a colonoscopy?" She says, "Oh yes, I've had 3." And that to me was shocking, because the first colonoscopy was normal. Who on earth would do a second and then a third colonoscopy in the same young individual, and then the cost of that, and then of course the morbidity of the potential risks of colonoscopy. So anyways, my point is, you don't want to do unnecessary colonoscopy. IBS and SIBO patients are subject to so much unnecessary testing. We're trying to simplify things. But we do know that if you're over age 45 now, according to the AGA guidelines, everybody should have a maintenance colonoscopy to rule out polyps and precancer stuff, because colon cancer is something we can find and cure before it gets too far along.
And let's say you're 45 and it's all clear, then do you have one every 10 years?
Yeah, if it's 0, no polyps, no nothing, then it's one every 10 years is fine. If you do find a polyp and it's one of the ones that could turn to cancer. It's all out. You take it out on the same visit, but it means your garden grows polyps, and we should check it sooner. Usually after the first polyp, you check every about 3 years, and if there's no more, then you can extend it to 5 and 10 if they continue to be no more polyps in the garden.
I love that your garden grows polyps. I've never heard that. How is methane predominant SIBO different? Are the symptoms different? Is the treatment different?
So we know a lot about the methane, because the methane is something we sort of figured out in 2005, and we continue to be intrigued by it. But methane itself, if you put methane into the gut, no bugs, just methane, you'll cause constipation. So we know that the constipation is proportional to the amount of methane. The brilliance of that, in the sense that the problem with overgrowth is it's generally a group of bacteria that build up. The brilliance of the methane is it's really one bug. One bug gives us a chance to figure out a treatment for the one bug and not hurting the others. And so that's what we're working on right now, is a drug that just blocks methane production just by that one bug and doesn't hurt the other bacteria, because you don't want to wipe everything else out just to get the one. And so we're trying to be boutique about how we treat just that one organism that's out of line and put it back in place. So, but the symptoms is what you were asking. The symptoms are generally a lot more bloating with the methane bugs, because not only are they creating gas, they're slowing the gut down such that the gas can't be expelled, and so it's building up and doesn't even come out. And I have a lot of patients, what they refer to it as, and I've heard this often, is trapped gas. They feel like the gas is there. They wish they could pass it in some way, shape, or form, but it's not moving. And that's typical of these methane patients. And they're miserable because methane's harder to get rid of. And so that's why we're looking for better solutions.
Does IBS and SIBO target specific populations, for example, more women than men, older people more than younger people, or is it an equal opportunity destroyer?
Yeah. So let me cover the women topic first, because this is something dear to my heart, that because for so many years it was blamed on your gender, it was blamed on your hormones, it was blamed on various things, and women were more nervous. And then about 3 years ago, one of our fellows, she's a female fellow, was preparing for her boards, and she went to a board review course, and one of the senior doctors who gave the lecture on IBS at the podium said IBS is a disease of hysterical women. And I was just shocked, because that's a dogma or a mindset from the 1990s and before that. To hear somebody say that in 2017 was repulsive, because that's not true. What we do know is true is that food poisoning is more likely to cause IBS in women than men. And we know food poisoning leads to an autoantibody. So women get more autoimmune diseases than men. Lupus, rheumatoid arthritis, they're more common in women than men. So there's something physiologically different, but it's organic, it's real. It's not psychological. It's not stress or anxiety. It's not because you don't blame the woman for her disease. And this is the stuff that I've been fighting against for 20 years, and to hear it in 2017 kind of shocked me. But there are still doctors out there, antiquated thinking, who think that way. So,
well, thank you for what you're doing. And I know that it's not psychological, but do you think that sometimes stress could aggravate it?
So if you look at stress particularly, stress aggravates or makes your motility of the gut more. It definitely gives you butterfly feeling and sensations in the stomach, and chronic stress can affect the gut, but we don't believe stress is the primary cause of IBS. And we know this because of a very large military deployment study where people were deployed to Iraq and Afghanistan. Thousands and thousands were studied in this trial. And even though they were in active combat in the most stressful situations you could imagine, they came back with IBS, but it wasn't related to the degree of stress they experienced. It was related to whether they got food poisoning in Iraq or Afghanistan more than anything else. And so my point is, stress makes it worse. Yes, stress is not the cause of it. And I hear this over and over with my patients. They say, I'm on vacation I'm still having IBS. Some things are better, some things are worse, but I'm still having IBS even though I'm very relaxed here. So I think patients themselves agree that stress makes it worse, but it isn't. Just when they're not stressed, it's still there, is my point.
Right. Thank you. I agree. It didn't cause it, but if you already have it, if you go through a stressful period, maybe you'll experience more symptoms. And that could be with almost any condition, really.
Right. Stress exacerbates blood pressure, it exacerbates arrhythmias of the heart, it exacerbates breathing problems, asthma. So yes, stress is a factor in a lot of diseases.
Right. So does this disease target certain age groups more than others? I mean, are there young children that are actually experiencing IBS and SIBO?
Yeah, so it's interesting. The younger you are, the more pain is the predominant symptom. So for kids, pain is a predominant symptom. The problem with children is that their diets are a little more indiscriminate. If there's ice cream in the room, they're going to pound the ice cream. They don't think about some of the repercussions if they have IBS, but also children describe their symptoms differently. And they're more resilient in some ways and more symptomatic in other ways. But if you can imagine, for viewers of your program who have IBS, if they do, imagine when you have severe pain from your IBS, and imagine a 8-year-old in a classroom having that pain almost doubled over, how they can, learn. I mean, it's impossible. It's impossible to focus. It as an adult, and imagine in a child, and they're perplexed as to what's causing this, and they're worried that it's something bad, and they're not sure how to explain it to their parents or their doctor. And so the doctor thinks they're stressed because their grades are bad, and their parents are stressing them because the grades are bad, but really it's the GI illness. So yes, the children suffer a lot with this, but it can affect any age, and it can come on at any age. And so it's widespread. There is no age category that's spared.
Is the constipation form or the diarrhea form more prominent, or is it an equal kind of split?
Yeah. So, well, more women have it than men. We talked about that, but we think that's due to the autoimmunity. The more you go onto the constipation spectrum, so we did a study where we looked at a very large group of patients from extreme diarrhea, meaning almost exclusively diarrhea, not extreme in symptoms, but no constipation, only diarrhea, to no diarrhea, only constipation. And there is a difference. Men are more on the diarrhea side. So if you look at the patients who have only diarrhea, no constipation, it's 2-to-1 men. So men are out representing women. If you go to the other opposite end of the spectrum where it's constipation, no diarrhea, it's 8-to-1 women. So 8 times more women have that extreme form of constipation. So yeah, there are gender differences that remain to be explained.
Is it true that you see an increase in hypothyroidism in people with IBS? I read that in an article once.
It's always important to look at thyroid in patients with changes in bowel function. It's a little bit in the old textbooks. The problem with textbooks, old textbooks, is that a lot of the stuff that used to be described in medicine was, like you have the doctor who came to a small town in the Midwest once a month, and by the time they got to that small town, that the farmer comes in with something the size of a football on their leg, and that's a tumor on their leg. And they said, "How long have you had this?" "Oh, I've had this for years. We just didn't have time to see the doctor." So textbooks are written on these extreme things and what a full presentation of a disease looks like. With medicine being so accessible, we often see sort of the borderline cases. They haven't quite become super hyperthyroid or super hypothyroid. But we do see thyroid disease, and it's something to look for. But you have to measure thousands of thyroids to find the one with the really unusual thyroid. So I don't know if I've answered your question, but it's not as common as you might believe, but you should look for it.
So how do we avoid getting it in the first place? And once we have IBS or SIBO, is it something that we're just going to have to deal with the rest of our lives?
Well, so this is what we're working on desperately. We now know the cause of SIBO in part, maybe 60-70% of those patients caused by food poisoning. We know the antibody that's causing it. If we can get that antibody out of the blood, we can cure this. In the meantime, we do use antibiotics quite frequently, and they do work, and they do keep the, you can have the symptoms gone for a few months at a time. And there are ways that we use, for example, prokinetics or drugs that make the gut move, so that once you've used the antibiotic, you can use the prokinetic or the drug to make the gut move forward to prevent the bacteria from building up, sort of like mowing your lawn so that the weeds don't grow. And so we do use that quite often. We can keep the bacterial overgrowth away for 6 months, a year for some patients. And then we also use diet. And I'm sure diet's going to come up in our interview at some point.
Oh, you bet. I can't wait till we get there. But I still want to talk a little bit more about this because people without the SIBO and the IBS, it seems like they suffer for just as much and for just as long. And I'd like to know how not to get these diseases in the first place,
So,
into prevention.
one point of advice is when you travel, so everybody loves travel, and even despite the
Not me. I absolutely do not like to travel. I love, as bad as this COVID-19 thing is, the best thing about it is I get to stay at home.
Yeah. Well, but for some people, they do love travel. But the other thing is that eating carefully is really important. And because if you get food poisoning, there's a good chance you could develop IBS. In fact, the rate is 10%. So if 100 people went to a wedding, which you probably do go to weddings, and the food was not quite prepared correctly, and 100 people got salmonella, 10 people would end up with IBS permanently or for an indefinite period of time. So hard to avoid at a wedding, but when you talk about good eating behaviors, eating off a food truck or going to exotic locations in the world and eating street food may not be a wise way to behave because you're putting yourself at risk. And, some people say, well, I've done that for years. Okay, you can keep spinning that roulette wheel and see if you never get it. Maybe some people are resistant to getting it. But my point is, that's how you get it. That's what you really need to avoid. And there's a whole laundry list of things you should do about eating safely when you travel. And we could get into it if you wanted to, AJ.
Well, actually, I'm a little weird. I won't eat at restaurants. I'm actually a chef, so my food's better, but I actually bring my food everywhere. So even when I go to a wedding or a bar mitzvah, I don't eat anybody's food. So that's how I protect myself. But I'd like to know, for people with IBS without the SIBO, what are you using to treat it? Are you using certain medications or other therapies that are helping them?
So if it's IBS and they don't have SIBO, if it's so they don't respond to antibiotics, we would try it anyways, because rifaximin is sort of a first-line therapy for IBS now with diarrhea. Then we might try things like, for example, for constipation, there's a number of drugs that can be used. A drug called linaclotide, which is secretes more fluid. Lubiprostone secretes more fluid. Plecanatide secretes more fluid. There's now the prokinetics that have come on the market again, and prucalopride is I'm trying to use generic names. Prucalopride is the newest drug, very effective at making the gut move. So I'm of the mindset that I like to make things move, not make it more liquidy, because I don't think diarrhea is the treatment for constipation, because now you're flipping from one problem to the other problem. I prefer to titrate these medications to have a normal bowel movement. In the case of bloating, it's more challenging because not a lot of things help for bloating. Gas-X is used frequently, but it's not that effective for patients with this kind of intense bloating that we see in our clinic.
Right. So you mentioned normal bowel movements. So now we get to talk about the Bristol stool scale. What, according to Dr. Pimentel, what number is the perfect poop?
Oh, 3 and 4. Those are the perfect poop. And so what I like to do in my studies, and so I don't want to get into too much of the weeds here, but the FDA, when you have a patient who's constipated, the FDA wants the outcome measure to be less constipated. But that is not really an ideal outcome measure. When I design our studies, what I want to see is the proximity to 3 and 4. So let's say you're constipated. If your drug, the drug you're testing in the trial, makes you have diarrhea, according to the FDA, you have less constipation. So that's brilliant. You win. You get FDA approved. But I want to see a drug that makes you normal, not makes you have diarrhea if you're constipated, or not makes you constipated if you have diarrhea. So I'm looking for Nirvana, the 3 and 4.
Great. Well, as long as we're talking poop, there are people that don't have IBS and SIBO, and there was once a television commercial that says normal is what's normal for you. And they were implying that you weren't supposed to move your bowels every day. Aren't you supposed to poop every day at least once?
So some of the old trials that determined what is normal. Okay, so this is now going to get a little bit scientific, but also just you have to understand the trials that were done on normal bowel movements did not exclude IBS patients. And since IBS patients encompass 10 to 12% of the population, making your bell curve means you're going to have some IBS on the constipated side and on the diarrhea side of your equation. And so the determination was 3 times a week, up to 3 times a day is normal. Okay, so that's what we ended up with. But the reality is, like, I'll give you an example. So I have a diarrhea IBS patient. I've given them rifaximin. They come back and they say, I wake up in the morning, I gotta go. I go, one wipe, I'm done. I know this is gross, but one wipe, I'm done. I'm on with my day. I've never seen anything like that. And it made me question what the normal bowel habit is, because after seeing an IBS patient become more normal than even some normal people think they are, it suggests to me that there is a normal. And the normal is you should wake up in the morning and have a bowel movement. It should be clean. It should be easy to get out. And the other thing that I often tell my patients is if they have pets, especially dogs, because dogs don't bury their poop, the dog defecates in the yard. They don't wipe. They don't do anything. It falls off cleanly. It's perfect every day. And why? Why is it perfect every day? And why can't we be that way? And so I just want people to understand what is normal, because I'll have patients come to the office and they'll say, "Oh, I'm normal." And I said, "No, but tell me about your bowel movements." No, I'm normal. And then I have to sort of fight with them to figure out that, no, that's not anywhere near normal. That may be how you've been for 10 years, but that's not normal. And I'm not trying to create a disease with somebody who doesn't think they have a disease, but I also need to know what is the true bowel movement they have, because it's surprising how many people, just because they've lived with it for so long, they think it's normal.
This was great. And, if people did have these normal bowel movements, like you explained, nobody would have had to hoard toilet paper during the pandemic.
Yes.
And you're so right. We are the only species that uses toilet paper. I noticed that with all animals, they never have to wipe. So yeah, I thank you. That was a great explanation. First thing in the morning, one and done, but preferably get out of bed first.
Yes.
That's great. So you mentioned that rifaximin is being used for IBS with diarrhea, whether or not the person has SIBO. Could you talk a little bit about this medication and the story behind it? Because I'm not sure everybody is familiar with it.
Yeah, it was something that we thought up in 2001. We were using antibiotics. Okay, so now this is back in the day when the microbiome as a cause of IBS was heresy, because people thought IBS was psychological, like we talked about earlier. And we were seeing, based on a trial with neomycin, an older non-absorbed drug, that IBS patients were getting better. So, but we needed something safer. We needed something that didn't cause resistance. And so we began some discussions with some companies around rifaximin and began some trials. And the first trial was successful, leading to subsequent trials. And it took about 12 years to get FDA to approve rifaximin for IBS, because imagine an antibiotic treating IBS 20 years ago. It was really unheard of and unexpected. And when you're changing things that dramatically in terms of science, it takes time. But rifaximin doesn't kill bacteria in the colon. It only kills bacteria in the small bowel. Part of the reason is because it's not soluble in water, and the bile in the small bowel helps to solubilize it, making its effect better there. And it kills the 2 bugs I talked about, E. coli and Klebsiella, very well in the small bowel. We proved that in some animal studies. And it's highly effective at getting rid of overgrowth, and as a result, treating the overgrowth in IBS patients.
Great. So what's the relapse rate like in SIBO, whether or not people use this antibiotic?
There's many numbers to quote. So remember, my clinic is the sickest of the sick in IBS, and so they tend to relapse more frequently, or a better way to say it is the patients that are now sent to me are ones who don't respond to rifaximin. But back in the good old days when nobody knew about rifaximin but us, and we were starting to give it, we were seeing patients relapse 2 years, some patients 6 months, some patients 1 month. And that's sort of what we were seeing. But even in the largest clinical trial that's done in rifaximin, a third of people who respond to rifaximin never relapse, which is amazing. So you think about, I think about my daughter. She's 21. If she had IBS and I wanted to put her on all these various drugs that are out there for IBS, if I gave her something and she didn't need to take a drug every day for 6 months, that's great. So my point is, it was remarkably effective, and I think that's why it's been so successful. But it's not perfect, and there are people who don't respond to it, and then there are people who relapse in 3 months. But if you look at the data from insurance carriers, people who take rifaximin, they take it about I think the data is 1.3 times per year. So it's not being used every month for patients. It's being used relatively infrequently in the general population because, again, remember, most of IBS in the country is at the primary care level and is not as severe as what I see in my clinic. And so those patients probably respond even better.
So is it the kind of thing, if somebody is going to respond to rifaximin, that they do right away, or do you continue to give it multiple times to see if they respond?
So the way I handle it is, if I give rifaximin and they respond brilliantly, then it's definitely it's working, and they're I don't need to give it until they relapse again. But if they respond 50%, so let's say they come back and they say, I'm 50% better. This is great. I've never been 50% better. Then I might give them another course. If they respond 0, like they literally took it and a 0% response, I'm not going to give it 2 and 3 times. It didn't work. That's not what's going on. We need to open up our toolkit and figure out there could be something else more sinister. So within 2 weeks, I know whether I need to do something more aggressive to look for things or whether this is just plain old SIBO IBS.
Great. Do you ever worry about the downside of repeated treatment with antibiotics, like, for example, on the microbiome?
Oh, absolutely. And that's part of the reason why in the Target 3 trial for rifaximin, the microbiome was studied, bacterial resistance was studied, and even though it's not 10 courses of rifaximin in the trial, it was 3, and after 3 treatments, there was no resistance of any consequence, and the microbiome was 98% identical to the beginning. So again, showing that rifaximin wasn't working in that colon and wasn't affecting your normal flora. So that was very reassuring and should be reassuring to your viewers as well.
I hear a lot about these fecal transplants for certain things. Are they ever using those for IBS and SIBO or any of the other conditions that you're treating?
Yeah, I'd always warned people about fecal transplant probably not being good for IBS, because the problem with IBS is you have too much bacteria, especially in that SIBO instance. And so putting more may not be a good solution because you have a tendency not to handle the bacteria correctly. But now fast forward, we have 5 double-blind studies. People have actually studied this with real aggressive double-blind research, which is the gold standard of how to test something. In 3 of those 5 studies, placebo did better than FMT. In other words, FMT caused harm. So the jury on this is, do not give FMT to IBS. Do not do FMT in IBS because of the risks of causing worsening of symptoms. And I've seen these patients in my clinic where they've been stubborn. They go somewhere, they get the FMT, and it's in another state, and then they come back home, and then the patient and I are stuck with the consequences trying to wrestle back to their old IBS because it's much worse now.
Yeah, it just blows my mind. Like, I wouldn't mind being a donor, but I just don't think I'd like to be a recipient of anybody's. I don't know. It blows my mind, Anyway, so now we get to the fun part. We finally get to talk about diet. What diet is recommended in general for people with IBS and SIBO?
So there's a lot of diets that people are proposing, but one of the diets that's gained a lot of attention is the low FODMAP diet, based on some research starting in Australia. And the low FODMAP diet, well, let me start by saying the bacteria of the gut, the reason diet works is because the bacteria of the gut are utilizing components of the diet in ways that depend on what you eat. So, for example, if you have bacterial overgrowth and you eat high fiber or you eat non-digestible carbohydrates, you have a lot more bacteria in your small bowel sharing your meal, and now they're eating something you can't digest. So sucralose, for example, or even stevia and other products, the bugs are now using it. There's 0 calories for you, 100% calories for the bacteria in the gut, and they're producing things from these chemicals. So that's one aspect. And so what I tell patients is if you ate 0, your bloating would go away. But that's not survivable. So you want to get as limited, you want to limit as much of the non-digestibles as possible, and that's the low FODMAP diet. It's extremely restrictive because it's trying to eliminate as much of the non-digestibles as is possible. The problem with the low FODMAP diet, though, is what's the end game? Is this a long-term treatment for IBS or SIBO? And the answer is no, because there's nutritional deficiencies that are already detectable in studies from Michigan, even at 3 months. So once you're 3 months into the low FODMAP diet, you've already restricted things to your body that your body needs to the point where you can measure their deficiencies. And so as a result of this type of work, the low FODMAP diet has changed, and now they're saying reintroduction strategies and strategies to bring food back. A diet we've been using for about 15 years is a low fermentation diet. It's meant in a different way. So we understand that diet is not a cure-all for this. We understand that we can only do so much with diet without causing calorie restriction. And we also put into the mix, we also understand that humans are social animals, and we need to go out and go to restaurants, maybe not AJ, but we need to go to restaurants, and we need to see our friends, and we need to be able to sit in a restaurant and not ask the waiter 20 questions, embarrassing ourselves in front of our friends because we're so restrictive. So the diet was meant to be a little more liberating, and you could probably find in any menu in the country an item that fit perfectly our diet. So it's less restrictive than the low FODMAP diet.
Well, could you give an example of both of those? And could somebody like myself and many of my viewers who are following a plant-based diet find choices within that?
If you're talking specifically plant-based, if we go to the low FODMAP diet, that's challenging because they restrict many vegetables, and so it's very hard to be low FODMAP and plant-based. For the low fermentation diet, the jingle or the little thing we say is you can the roots and the fruits. So roots and fruits are more digestible than the leaves. So, for example, Brussels sprouts or cabbage or lentils are bad things for people to eat as vegetarian. But you can eat the eggplants, the zucchinis, the squashes, anything that grows underground, even onions, because onions are considered no-no on low FODMAP, are okay on our diet. But carrots, beets, all the things, potatoes, all the things that grow underground are generally okay on our diet.
That's great. So, because people tell me all the time, because things like cruciferous vegetables and legumes are recommended by many doctors, they're foods that are eaten in the blue zone. They say they're good for health and longevity. So do you think that one could go healthfully throughout life without eating many of these cruciferous vegetables, beans, or legumes and still have good biodiversity and a broad spectrum of the required micronutrients?
So the more restrictive you make your diet, the more you change the microbiome. So that is true. And that's why I started this conversation with diet by saying that diet helps a lot. Diet might help us need less rifaximin. Diet will help us have less symptoms when we're socializing with our friends by monitoring what we eat. But extreme diets are harmful and can have sort of lasting detriment. But let me put it to you another way. So going back to the dog analogy. So one of the things that we do in society in the United States is we eat Greek food one night, Italian the next, Indian food the third night, maybe Mexican food the fourth night, our microbiome doesn't know what the hell is going on because we're not. So Mediterranean diet, for example, they're eating feta, olives, tomatoes, maybe a little bit of meat, small amounts, mostly vegetable based, and they're eating the same thing every day. So it's regular, healthy, balanced nutrition, but the composition is almost the same every day. In Italy, the composition is almost the same every day. In the United States, we just want to eat everything. And so not only does it mess up your microbiome, and I don't mean that in a derogatory way, it's exciting to eat different foods. What I'm saying is if your gut is not healthy, eating this diversity really is challenging. It's challenging for your liver to figure out what food's coming next. It's challenging for your pancreas. It's because we're changing everything so quickly and rapidly that we can't fine tune our instruments for the food we're eating. I think that's more important. And that may be why dogs, going back to the defecation, have such great defecation, because they don't vary their food. They have a balanced diet every day.
I think I must be a dog because I don't vary mine much either, and I'm doing really well. Now, you mentioned that in as little as 3 months, people on a low FODMAP diet were showing nutritional deficiencies. Which deficiencies were they showing?
These were micronutrients. Certain minerals were deficient. I don't remember the exact list. Bill Che from Ann Arbor, Michigan, presented this at a meeting about 3 years ago, and it was really a catalyst for driving like selenium and other micro minerals is one of the things I remember. But Bill Che was one of the driving forces for why the FODMAP diet changed to reintroduction rather than being a steady diet.
So for people that don't suffer from IBS or SIBO or other gut issues, what's the best thing that they can do just to optimize their gut health?
Sorry, can you ask the question again?
Sure. So thankfully, not everybody has IBS or SIBO. So for the average person, what could they do like on a daily basis just to optimize their gut health?
The gut needs nutrients as well, because remember, these bacteria in the gut are helping you. They can hurt you, but generally they're there. Think about it this way, that they are there to provide you things at the same time they're benefiting. So we call that commensal, that we need them, they need us, and we're one big happy family. So eating a balanced diet is very important. I like to think eating things regularly, like you and I just spoke about, is sort of a good thing for the body in general, because you're not varying too much, and the instrument that is your body is well tuned. Varying things too extremely can cause problems. So I would say eating a balanced diet, and to be honest, I'm not against fiber. I think fiber is terrific if your gut is perfectly healthy and you're a healthy individual, because fiber keeps a lot of balance, and it also does feed some of the bacteria that are beneficial to you. It's just if you have a disease of the bowel or IBS, that fiber really causes more trouble for those individuals.
From a pediatric gastroenterologist in Southern California named Dr. Jim Tipton, and he said, "I have always wondered about one aspect of his landmark NEJM paper on IBD. They found that kids with the same genetic background who grew up in a third world country were less likely to develop IBD than kids of the same age and genetic background who grew up in the US. As I recall, they speculated that the differences could all be attributed to bacterial exposure early in life. I wondered if they ever considered that food is or could be healthier in countries without GMOs and factory farming." I'd be interested in Dr. Pimentel's thoughts.
So they're referring to IBD, but IBS is the same thing. So people have said to me, well, if food poisoning causes IBS, then why isn't underdeveloped countries full of IBS? Because food poisoning is common. We actually did this study where we took infant rats and we infected them with food poison, or not food poison, but Campylobacter jejuni. We exposed them to food poisoning, and then we did the same as adults for the first time. The adults got IBS, the infant rats did not. So it's the first time people are exposed to these environmental toxins or bacteria is when they're 1 year old or 2 year old in some of these countries. And it does something to your immune system differently. So think of it this way. If you get chickenpox as a child, not a big deal. Hepatitis A, measles, mumps, rubella, all those as a child, not a big deal. You get those for the first time as an adult, you can die. So the adult immune system is different than the child's immune system. And so that's part of it. The other part of it is, yeah, I think there is something to be said about GMOs and non-natural food items or food additives per se, like polysorbate 80 is added. It's an antibacterial. Sodium benzoate's an antifungal. This is in food to keep its shelf life long. What is it doing to our microbiome? We're going to figure that out, but it's going to take time. But we don't like what it's doing. I have many patients who say that they can't eat pasta, but when they travel to Italy, they have no problems whatsoever. I have heard that story 100 times, if not more, because the food there is more natural, there's no refinement or less refinement, less additives. So there's something to the story. We just need to unravel it from a microbiological perspective. So I agree with your question. I think there is a lot to that story that we'll learn over time.
You know, you're so right. I've talked to people that were even gluten intolerant that for some reason when they went to Europe, they could eat the bread.
That's exactly right. I hear that story over and over.
Yeah, so it must be true. So is IBS and SIBO mostly an American disease, or is this affecting other countries equally?
No, it does affect other countries, but in various prevalences, of course. In certain countries it's higher, in certain countries it's lower. But I think, as I mentioned, this issue about if you're a child and you get food poisoning versus as an adult, in America, we eat salad from a bag until we're 16, 17 years old. And then we go to Club Med as part of our first year spring break in college. And then we see Campylobacter for the first time. Now we have IBS. And that story I've heard many, many times. So, we're keeping things too clean. You remember your grandparents and even us, we went to kindergarten and we played in the sandbox and we ate the sand. Now everything is Purelled and sanitized, and it's probably the wrong thing to say in the COVID era, but what I'm saying is people weren't as afraid of things as they are now, and so these children their immune system is not developing because they're not getting exposed to all the things they should as a kid. And I think they get them as an adult and it's worse.
Well, since you mentioned COVID, I do have to ask, does having any of these GI conditions make you more susceptible to this virus or any virus?
Oh, we're learning so much about COVID every single day. What I will say about COVID, and I can't say that the IBS or SIBO makes you more at risk. I don't know the answer to that. The data is still emerging because this is so new. But I will say that about 50% of people with COVID, diarrhea is part of the illness. And so if you do have, let's say you have diarrhea and suddenly it's much worse, unusually much worse, then you should really think about getting testing for COVID. So I think that's really important to think about, because they'll do a nasal swab and they'll find COVID in patients with this diarrhea. They won't test your stool, they'll just test the nasal swab. And some of those patients later on have a worse, more severe illness because it started in the gut. So just be mindful of that.
Thank you. So the next question is from another gastroenterologist in Los Angeles named Dr. Robert Gross. And he says, Dr. Pimentel has some fascinating new information on the IBS SMART test. Please ask him about it and how it relates to the pathophysiology of IBS. And his history of how he developed his ideas are also worth exploring.
Well, thank you, Dr. Gross, for that question. It took about 10 years to describe or to discover what the cause of IBS was through this mechanism of food poisoning. And so if you are positive on these blood tests, the IBS SMART blood test, which measures anti-CDTB, which CDTB is the toxin, and anti-vinculin, which is the autoimmune marker, you're more than 90% likely you have IBS. And so first of all, it's enabling for the patient. The patient now knows it's not psychological, which is huge. Secondly, if food poisoning caused your IBS, you know it, you better not get food poisoning again, because these antibodies go higher, and the higher they go, the harder you are to treat. We know that now in our clinic. And so it tells the doctor, stop doing all the unnecessary tests, saves money, It saves the patient the headache of these tests. It validates the patient that it's not in their head. This woman who's 24, it's not because they're hysterical. It's because they have a previous history of food poisoning. Now what we're trying to do is we're trying to say, okay, now if we can get rid of that antibody, can we cure IBS? That's where we're heading. So a couple more years for that, and that's the exciting part of that discovery.
So do you think the future is bright for those who suffer with these conditions?
Absolutely. We're more excited than ever because it's one thing when you don't know the targets, but when you do know the targets, then it's not the destination to the goal is now finite. We actually know we can get to that goal. It's just time.
Great. So Dr. Pimentel, what is the truth about GI health?
The truth about GI health is this. We don't really know what normal bowel habits is. We've talked about that today. But what I would argue is that if you do suffer from GI health, don't be embarrassed to talk about it, because this problem was created by doctors because doctors were considering patients with these unusual symptoms as psychological. We don't do that anymore. And if you find a doctor that does, get a second opinion, because most doctors don't do this anymore. The second thing is it's really important to understand that a balanced diet means a balanced gut. And the microbiome of the gut is a hot topic right now, and a balanced diet also equals a balanced microbiome, which keeps you healthy. It's all harmonious, and if you can maintain that balance, your gut will be healthier in the long run.
Great. Thank you so much for your passion, your compassion, and for the work you're doing.
It was great doing this interview, AJ. Thank you very much.
Take care.